here today with my colleague, Dr. Robin Chaka, who's a fabulous breast surgeon here at Lankenau Medical Center. And I wanted to talk to you today, Dr. Chaka, about how breast cancer care has changed at Lankenau because of the COVID crisis. Can you tell me a little bit more about the classification that the guide we now have to work by that tells us who needs treatment now, who can wait, and all that? Tell us how you're managing all that.
Hi, Marisa. So in early March, when the pandemic started to affect all of us here in the United States, patients, our family members, those of us we're taking care of, many of the organizations that establish guidelines for patients, even under normal operating times, set up some guidelines to guide us in the care of breast cancer patients. That includes the American College of Surgeons, the American College of Radiology, American Society of Breast Surgeons. Basically breaking up surgeries, and these are actually principles that you can apply to all types of cancers, but as specific for breast cancer, breaking it up into three tiers. Tier A or tier 1 being surgeries that cannot be delayed. These are emergencies and basically situations that have no other options. That would include patients who have an abscess from either a surgery or some other issue, and patients, more importantly, with breast cancer for whom there are no other therapies that we can delay their care. That will include some patients with triple negative breast cancer or patients who have completed neoadjuvant chemotherapy prior to the pandemic and needed to proceed with surgery. Tier B are the group of patients which mostly would include early stage, recently diagnosed breast cancers. Most of these would be patients with hormone receptive positive disease or other disease subtypes that may be able to have chemotherapy first and then have their surgery delayed until after things have settled down a bit with the coronavirus.
And in that tier B, are there also patients whose treatment can be delayed by being put on hormonal therapy first?
Yes, yeah. So these are patients that we would consider that normally would have surgery first due to the size and the presentation, but we could consider putting them on hormonal therapy such as tamoxifen or aromatase inhibitor to hopefully keep things under control and then be able to delay their surgery till it's safe for, to proceed with surgery for them and for all of us at the hospital. I think that, some patients obviously don't like delaying things, but I think it's important to remember that this is something that actually was standard of care even before the pandemic. I mean, we would often do this for very large hormone receptor positive cancers to try to downstage them and make them better surgical candidates. So this is not just something that's new from the pandemic. It's just that we're using something that's fairly well established in a different way in an attempt to minimize patients' exposures to the hospital and, kind of keep on board with keeping everybody home and keeping everybody safe.
That's really helpful because people who are on these medicines and who've had a change up in the order of things can be reassured that that they're still getting active treatment. It's just the sequence of treatments is being modified.
Correct. And then the final tier C or tier 3, are patients who we can delay surgery for a number of months, anywhere between 6 to 12 months. And the patients mostly in that category are patients with ductal carcinoma in situ or DCIS, which is a very, early low-grade lesion that we think that waiting a few months, even several months is not going to change their disease process or certainly not impact their survival. We are also offering hormone therapy for these patients while they're waiting to have their surgery as well.
And that hormonal therapy, we mean anti-estrogen therapy, like you said, like with like an agent like tamoxifen, as well as an aromatase inhibitor. And then we also have in that category, patients who may be at high risk for breast cancer or who have a known inherited high-risk breast cancer genetic alteration, who were planning to have prophylactic surgeries. Their surgeries too have been delayed. Is that right?
Yes, actually, those 2 patients I had on the schedule very early in the pandemic in March were 2 of my patients who were the first affected, so to speak, as far as my specific patient population. Luckily for those patients, they were up with their screening, they had their MRIs, they had their mammograms pre-op, so certainly delaying their surgery is not going to have any impact on their overall care. And, for patients out there who were considering prophylactic surgery or also had, I think as long as you're up on your imaging, waiting a few months to have surgery and minimizing your exposure, to the virus is certainly the right thing to do.